Good morning, friends, and good morning to the members of the PCOS Society, and a big thank you to the organizing committee and the CSI for having me over to give this talk on management of chronic coronary disease and acute coronary syndrome, which is a large topic to be covered in 15 minutes. Well, we do know that coronary artery disease is a pathological process which is characterized by plaque accumulation in the epicardial arteries, whether they are obstructive or non-obstructive. Usually, they can have long stable periods, but they also become unstable at some point of time, and basically that's because of plaque ruptures, and that defines the transition from chronic coronary disease to the acute coronary syndromes. Most frequently encountered scenarios, usually patients with chronic stable CAD and chronic stable angina symptoms. Some patients will present with acute onset heart failure. Some patients will be asymptomatic or symptomatic with stabilized symptoms less than a year after an ACS or more than a year after an acute coronary syndrome or revascularization. And some patients may have suspected vasospastic disease. And of course, you have a large amount of patients who are asymptomatic, which are detected purely on screening, and they do not come to light otherwise. Most important part of angina, of detecting chronic or unstable angina, is the history taking. And usually you look for symptoms like fatigue, faintness, nausea, burning chest, and then the chest, restlessness, or very often they say that, a sense of ghabrahat or a sense of impending doom. And these are usually exacerbated by exercise, exacerbated after meals. There's something called as walk-through angina, and the threshold may vary from patient to patient. If you talk about typical angina, you have a constricting discomfort in the middle of the chest, which is precipitated by exertion, relieved by rest, and this may radiate to the neck, jaw, shoulder, or arm, anywhere above the umbilicus and up to the angle of the jaw. You call it atypical angina if it meets two of the characteristics. If you call it chronic non-angina chest pain, if it meets only one of these characteristics. And the differentiation of stable versus unstable angina is that unstable angina presence is rest angina, new onset angina, and crescendo angina. There's a low, if you define a low risk in unstable angina, if there's no recurrence, no heart failure, no EC changes, and no increase in the troponin levels. And here you see that as the symptoms worsen over a period of months or years, the risk increases. And if you treat them in between, the risk definitely goes down with adequate therapy for secondary prevention. The basic investigations, as all of us know, is the ECG, a 2D echo, and ECG monitoring, ambulatory ECG monitoring, X-ray chest, and in some patients a stress test, and of course there are biochemical tests. And today there's a huge hype on CT calcium scorings. The reason why we use these non-invasive tests is to detect myocardial ischemia through ECG changes, wall motion abnormalities, and perfusion changes through SPECT or PET CMRs. Of course, the nature of investigations goes through usually non-investigation and non-invasive testing. And if it is positive, you either give a drug therapy or you can today go in for a CT coronary angiogram. And in case of ongoing symptoms, do an invasive angiography in these patients. There are certain risk calculators which help us in guiding the treatment of chronic disease. One of them is, of course, the Framingham risk calculator, which is one of the earliest risk calculators based on these 4 parameters. And you have the SCORE risk calculator, which is based on gender, age, cholesterol, systolic blood pressure, and smoking status. And recently, they have the SCORE 2 and the SCORE for older patients. The determination of the likelihood depends upon the presence or absence of an abnormal ECG, presence or absence of coronary calcium on CT. The absence of calcium does not mean no coronary disease. Of course, a high probability if there are ECG changes, abnormal ECGs, LV dysfunctions. When you come to treatment of chronic stable disease, of course, the most important part is lifestyle modification in terms of smoking cessation, healthy diet, physical activity, healthy weight, and medications to control risk factors. And this is a very common thing, common factor with smoking cessation, which is not so easy, but we need an active, aggressive, passive approach in asking them to quit smoking. Pharmacological management of chronic stable disease includes anti-ischemic drugs like nitrates, beta blockers, calcium channel blockers, and of course, the use of statins, antiplatelets, and they're not anticoagulants, antiplatelets, aspirin, clopidogrel, Ticagrelor, and prasugrel. Use of nicorandil, and of course, the use of evaporatin, which is a beta blocker with selective effects on the heart rate. When we come to the management of ACS or acute coronary syndrome, the important part is when do you go invasive in these patients? And the focus is on oral antiplatelets. Why do we, again here, we need to stratify the risk. Why do we need to stratify the risk? And that's basically because the mortality of any of these the disease spectrums depends upon the risk and the poor, I mean, and you know that there's a poor survival rate in high-risk patients. And there you need to be aggressive in giving the right treatment. The diagnostic algorithm begins in the ER, where you need to triage these patients depending upon the ECG and the troponin values and decide whether they are non-cardiac or they fall into what we call as non-ST elevation MI or ST elevation myocardial infarction, which is the actual infarct status that happens. And the triage can help in ruling out or in ruling in the presence or absence of non-ST elevation MI by looking at the troponin values. And of course, you look at CT angiograms or other invasive imagings in case there is a reason to doubt that these patients may be a high suspect for an NSTEMI or for evolving ST elevation myocardial infarctions. There are differential diagnoses of acute coronary syndromes in the acute setting of chest pain. You need to rule out all of these, in whether it is cardiac, pulmonary, vascular, gastrointestinal, orthopedic, others. And that's where the triage of these patients comes into effect. And you can easily rule in or rule out, in most of these cases, the presence or absence of coronary syndromes. In case of non-ST elevation MI, there are two risk scores. One is a TIMI risk score based upon certain 4 historical parameters and 3 parameters on presentation. And this is a score of 0 to 7. And depending upon the risk score, we know that the mortality increases as the risk score increases. We classify them into mild, moderate, and severe. And it has shown in terms of validation that there's an increasing event rate with increasing TIMI score. And it's a very simple bedside tool. The GRACE risk score is the other part of the scoring, which is again based upon certain parameters like age, heart rate, systolic blood pressure, Philip class of the patient, and the value of creatinine. And also certain dynamic factor patterns, which help us in calculating what is the risk score. And we calculate them as low, intermediate, or high, depending upon the risk score. And of course, on the right-hand side, you can see that the in-hospital deaths are directly correlated to the risk scores. So this is again a multinational perspective, and it's a very simple scoring system which can be done on the bedside, helps us in deciding how to treat these patients. In terms of the management algorithms, when we look at the definite or likely NSTEMI MI, we need to have an early invasive strategy and initiate aspirin and P2Y2 inhibitors like clopidogrel, ticagrelor, or anticoagulants, and then triage them into either an angiography with angioplasty or a bypass surgery. If it's a bypass surgery, you need to discontinue ticagrelor and clopidogrel at least 5 days prior, and prasugrel 7 days prior to an elective CABG. In terms of factors associated with appropriate selection of patients, we have the groups of early invasive and delayed invasive, where the risk score is more than 140. There's a change in the troponin values and new or presumably new ST depression. And in delayed invasive, which is more than 24 hours and between 72 hours, in patients with renal insufficiency, reduced LV systolic function, post-infarction angina, and if you have had a recent angioplasty within 6 months or prior bypass surgery. In terms of recommendations for coronary revascularization, hemodynamic instability or circulatory supports, refractory angina, life-threatening arrhythmias, mechanical complications of MI, heart failure, and presence of ST depression more than 1 millimeter to more than 6 in more than 6 leads, which is a class 1 indication. It's also recommended in those patients where a diagnosis of NSTEMI is suggested and the GRACE risk score is more than 140. In those patients whom we're not sure about the strategies, you can do a CT coronary angiography to detect the presence or absence of coronary disease. The use of P2Y2 inhibitors, which is a major issue as far as treating patients with coronary disease is concerned, and it becomes a problem when you have to take these patients for any non-cardiac surgery. You need to understand 2 things. One is that aspirin is a thromboxane A2 inhibitor. The P2Y2 inhibitors are ticagrelor, clopidogrel, and prasugrel, of which clopidogrel and prasugrel bind the platelets irreversibly. Ticagrelor is a reversible calculation. In terms of clopidogrel, it has proven its worth in the treatment of unstable angina and has improved the mortality in all the studies that have been conducted so far. And as far as clopidogrel is concerned, As far as the use of limitation, as far as the limitations of clopidogrel is concerned, there is an individual variability in response and a low level of platelet aggregation in some patients. And in some patients, you have what is called as clopidogrel resistance. And that's seen in about 5 to 44 patients of 44% of the patients worldwide. And that is why, one of the major factors in the treatment in the use of clopidogrel. Prasugrel is an irreversible binding. There have been various studies of prasugrel in invasive management, non-invasive management, but the issue has been that there has been an increase in the cardiovascular death and TIMI major bleedings in patients who have been in patients who have used prasugrel as an initial management in the setting of a non-ST elevation myocardial infarction. So it is recommended that prasugrel pre-treatment non-ST elevation MI is not actually recommended unless the angiogram has been done and there is a role of revascularization because of a 3-fold increase in the incidence of TIMI major and non-CVG bleeding, and is almost 6-fold increase in life-threatening bleeding with prasugrel pre-treatment compared with no pre-treatment. What about ticagrelor? Ticagrelor has been studied widely. And one of the major studies was a plateau NST elevation ACS study, which is basically comparing ticagrelor with clopidogrel in over 18,000 patients randomized to angioplasty or to bypass surgery. And of course, in these patients, it is very well seen that ticagrelor has approximately 17% risk reduction as compared to clopidogrel in reducing the all-cause mortality and myocardial infarctions. No major, in terms of efficacy, it is definitely efficacious and a trend towards better efficacy in cardiovascular death and all-cause death. No major complications or no major difference in the bleeding complications, either whether it is compared to major bleeding or non-CVG major bleeding in the use of ticagrelor compared to prasugrel. Antithrombotic therapy is an extremely important part of the management of ACS. And of course, it depends upon the patient's characteristics, clinical presentation, comorbidities, co-medications, and procedural aspects whether the patient needs to go in for a specific procedure or not. The use of ticagrelor and clopidogrel is well established. Prasugrel still remains a point of question of query. The last point of my talk is the management of ST elevation myocardial infarctions. Of course, we do know that primary angioplasty is the mainstay of treatment. But in our country, fibrinolytic therapy also has a role to play because of various aspects. So the question has always been that can we improve on primary PCI with concomitant fibrinolytics? Should all fibrinolytic patients go to angioplasty? And should only fibrinolytic failures go to PCI? Because of various statistical and logistical delays in the management of STEMI and the non-availability of cath labs, we do have a place for pharmacoinvasive approach where we administer early fibrinolysis using a fibrinolytic agent and then systematically perform an angiography within 3 to 24 hours after the start of fibrinolytic therapy. And in case there's a fibrinolytic failure, that window is reduced and the patient can be taken up earlier. The reason for so much stress on this approach is that time is myocardium. And for each 30-minute delay in the treatment of a patient, the 1-year mortality increases by 7.5%. The mortality benefit primary PCI is lost if PCI-related delay exceeds 60 minutes. And practically, early fibrinolytic therapy can compensate for any angioplasty-related delay. Where is it indicated? It is appropriate for patients with ST elevation MI who are eligible for treatment with fibrinolytic agents if the transfer time is more than 30 minutes from a peripheral hospital to a PCI-capable hospital, or the door-to-balloon time is more than 90 minutes, or if in the hospital, the angioplasty-related delay, there is a door-to-balloon minus door-to-needle time is more than 60 minutes. Our basic aim being to shorten the time to reperfusion of the infarct-related artery. There are certain pros and cons of using a lytic before angioplasty. The most complicated being bleeding diathesis, prothrombotic state, cost, and a slightly higher incidence of stroke in these patients. The guidelines clearly state that primary angioplasty is the gold standard of treatment, but where this is not possible, fibrinolysis should be performed with a fibrin-specific agent as soon as possible within 10 minutes from the STEMI diagnosis. However, in our country, the use of streptokinase as a primary thrombolytic agent is still a major role in a lot of rural areas due to inaccessibility to the fibrin-specific drugs. And in the first 3 hours of an event, primary angioplasty and fibrinolysis are head-to-head. The fibrinolysis is equivalent to that of a primary angioplasty if the delay is more than 120 minutes. And as time passes, primary PCI is probably a better option than thrombolysis because of various factors associated with fibrin binding within the platelet-rich thrombus. And these are certain flow charts as far as the management is concerned. The basic aim of treatment being to achieve fibrinolysis or an open infarcted artery within 120 minutes of the first patient contact. Again, the same that if we have delay in the PCI, we would rather thrombolyze these patients and then transfer the patient to a PCI-related center so that there's optimal management of these patients. Recommendations are that reperfusion should be given to all patients, and there are 2 registries in India, the CREATE registry and the Kerala STEMI registry, which shows that a lot of patients in India do not get appropriate treatment for ST elevation MI or non-ST elevation MI. And a lot of these patients go home without the appropriate drugs also. So that needs to be a sea change as far as the management of ST elevation MI is concerned. So I hope I have conveyed to you a brief about the management of chronic coronary syndromes and the management of acute coronary syndromes in whatever time frame I had. The basic remains that we need to save muscle. We need to save the heart, the muscle in order to achieve a better long-term result, because heart is one muscle which once it is damaged, it never recovers, and you have to live with it a lifetime. Thank you very much for your kind hearing.